media wizard and has been awesome with helping us get set up. And Kyle, you want to stand up? Kyle's we're doing live streaming, and so this will be available hopefully also on YouTube afterwards. So thanks for coming. We have a great turnout. I think we have about 100 folks this year from all over. There's folks from out west, from Western Canada, New Brunswick, and even Vermont. So we're going to try and move things along. Megan, I guess I'll have to talk about the hashtag stuff. Yeah. We have a reception this evening. Please come every night. We have a reception. Let's just kind of hang out with you guys and get to know you and just have a little fun. It's going to be great skiing. And also, you know, as we do this every year, for those of you who have been here before, thanks for coming back. And for those of you new, thanks for coming. Give us feedback about what you like, what you don't like, what topics you want. We try and get speakers based on that feedback, and it's been pretty fun to try and recruit folks to come for the topics that people want to hear. So without further ado, thanks for coming. Megan's going to talk a bit about what we're doing with social media.
Yeah, so for those of you who've had a chance to visit the website, it's dtemupdate.com. We're going to be including a link on the website that's going to embed our live stream, so the lectures are going to be available online. We're also trying to tweet out a lot for those of you who use Twitter for any kind of interaction with the medical community. But the hashtag for this is hashtag StowEM18, which was just up there, but it's not anymore. StowEM18. And what we wanted to do, we're going to have a contest over the next couple of days. We have a few gift baskets to give away. And so for the top tweet for each session, if you tweet out either questions or comments about lectures that you see throughout the day and include that hashtag, we're going to be giving away a gift basket for each session for the top tweet. So please tweet away. If you don't know how to tweet, get in touch with me or Peter or Kyle. Let us know. We hope to get everybody kind of social on here. So thank you.
And finally, we're going to try and move these talks through relatively quickly so you have plenty of time for recreation. We have a little bit of time after some of these for questions. If you don't get a chance to have questions, go ahead and tweet them. We actually will link them to the provider who talked. You can also meet out in the hallway. We're going to try and be accessible throughout the conference to go over some of the topics we discussed. All right, dude, hook on up. You got to turn your mic on.
Okay, we got it. All right, can everybody hear me? So this will come up in a second. So we're going to do GI bleed updates today. So I'm Mark Bisanzo. I'm one of the course co-directors with Peter, and I'm the associate PD for the residency. Thank you, everybody, for coming. I'm happy to be kicking off the conference this year. So first of all, I have no conflicts to disclose, unfortunately. So what we're going to do is, you'll notice if you pulled the slides off the CME site, I have 5 questions on the CME site, so I narrowed it down to 4 to kind of keep this at a somewhat reasonable pace. So we're going to talk about, answer these 4 questions. So first, does medical treatment for upper GI bleed help? Second, what's the deal with NG tubes? Are they actually useful? Third, when do I give blood? And then fourth, how do I dispo these patients? All right. So does medical treatment help in upper GI bleed, right? And basically the impetus for me to start giving this talk back 10 years ago when I first started giving talks on this was that I had a case where the person clearly needed to be scoped. I called GI, and the GI fellow, I was a resident, the GI fellow like bawled me out for not doing all this stuff that seemed totally irrelevant, and then made a whole bunch of excuses about why he didn't want to come in and scope the patient. So that was my impetus to start looking at it. So we're going to talk about 3 meds, proton pump inhibitors, tranexamic acid, and octreotide. So this is a case, you have a 48-year-old guy who's basically coming in with some nausea and hematemesis, vomited ×1 earlier. He's a little bit tachycardic, his blood pressure is a little bit soft, his exam's otherwise normal. So what do you want to do, right? So if you call GI, the first thing they're going to say is, did you give a proton pump inhibitor? So what's the data for this? So the idea is that the PPIs are supposed to raise the pH, which is going to make the platelets aggregate better, and it's going to basically inactivate gastric enzymes. The question is, does this actually work? So if you're going to give PPIs, you have to give a really massive dose of PPI to get the pH close to neutral. So the kind of low-dose PPI, even physiologically, shouldn't work. High-dose PPI, physiologically, maybe it could work. The interesting thing is that the bleed stops spontaneously in almost 3/4 or about 3/4 of the patients. So it's kind of like TPA, right? You push the TPA and then the person's stroke gets better and you're like, oh, it was the TPA. Well, maybe they stopped bleeding spontaneously and the PPI had nothing to do with it, right? So it's been studied a lot. There's been more than 2,000 patients enrolled in the trials. They've compared it to placebo and to H2 blockers. And the bottom line is that in terms of stuff that GI worries about, like stigmata of recent hemorrhage, there's less of that if you give the PPIs. There's slightly less need for intervention, probably because the patients are less likely to have an obvious source of bleed. But in terms of stuff patients worry about, like death, rebleeding, or need for surgery, there's no difference. So it does help some outcomes that are maybe relevant, because it would be nice if GI can get in there and kind of see what's going on and not have an actively bleeding vessel. But it doesn't help the kind of major things that the patients would worry about. So next drug, TXA. So this seems like every shift I work, we're coming up with some new indication for this. We're starting to use it for nosebleeds. It's being studied for postpartum hemorrhage. There's a lot of different uses for this. So I wanted to look into whether or not it was helpful for GI bleeds, right? So surprisingly, this has been studied since the 1970s because this drug's a really old drug, right? And it's inexpensive, which is great. There's been 8 trials done for upper GI bleed, and of the 8, they showed kind of a slight mortality benefit. The data is definitely not perfect, but there is a slight reduction in mortality. There's no reduction in bleeding, and rebleeding, which kind of makes you wonder where the mortality benefit's coming from, but there is supposedly a slight reduction in mortality. For lower GI bleed, there's only been 1 trial. And with the lower GI bleed trial, it was really underpowered. There was only 100 patients, and it showed no benefit, but it really wasn't powered to properly detect a benefit. The good news is they have this massive study going on called HALT-IT that's going to enroll about 8,000 patients, and that's due to finish up enrollment next spring. So we should have an answer for this in the near future. The bottom line, though, is I think especially if you're in a community site and you've got to transfer the patient for GI, or you're having trouble getting GI in, this is an antifibrinolytic, so it shouldn't promote clot. It should just stabilize the clot that's forming. So I think the benefit, it's a cheap, inexpensive drug that doesn't have a lot of side effects. So I think if you're stuck and the person looks really sick, at this point I would try it while we're waiting for this other trial. Next is octreotide, right? So octreotide is definitely talked about for variceal bleeds, but what about just in undifferentiated upper GI bleed? So the theory, again, with this is that it's going to decrease mucosal blood flow, make the person less likely to bleed. It's going to decrease the activity or secretion of some of the stomach acid and pepsin. It's been studied a lot in undifferentiated GI bleeders, and none of the studies are great, but there's not even any hint of a benefit. So if you don't think the person has cirrhosis, octreotide is probably not indicated. Now the question is going to come up is, what if they have cirrhosis, right? So here it's definitely more well established. So for the cirrhotic upper GI bleed, octreotide is definitely beneficial. They still need to get scoped, so they've done studies where they've compared it to octreotide alone to octreotide plus endoscopy, and the best outcomes are with octreotide plus endoscopy. So octreotide for sure if they're a cirrhotic. The next question for cirrhotics is, what else can you do, right? And so this is probably less well known, but I think is becoming more commonplace over the past couple of years, which is that these patients tend to get infections of all different varieties, and so giving them prophylactic antibiotics does seem to reduce mortality. This was originally studied with the fluoroquinolones, but as we all know, there's a lot of side effects to those, and they have a lot of problems, and so third-generation cephalosporins are kind of the antibiotic of choice for this now. All right. So you've got GI to come in for this upper GI bleed. You've kind of done a couple things, maybe given them some PPIs to keep them happy. And ideally you want them to get in and actually be able to see and not kind of have a stomach filled with blood and other stuff like you see over here. So what can we do? So there's two big pro-motility agents that are readily available that we have access to quickly in the ED. The first is erythromycin, and the second is metoclopramide. And these have been studied to see if whether or not you give them pre-endoscopy, if it helps to empty the stomach out. So the erythro has been studied more than metoclopramide, but you can see here there's at least 5 or 6 small trials that have been out that all show like a consistent kind of soft benefit. So, you know, it's not going to be like a life-saving thing, but it's probably going to make the scope easier for GI, and I think it's worth doing. So the dose is 250, about 250 milligrams about 30 minutes before endo. All right, next topic, or next question. NG tubes, are they helpful, or are we just torturing people, right? So this 33-year-old lady comes in. She basically has a medical history, or presents with coffee ground emesis, no medical history, denies any fevers, chills, chest pains. She recently started drinking a lot more after she lost her job. So her vitals show soft blood pressure, slightly tachycardic, but otherwise she looks pretty good. So the GI attending wants to know, what did the NG tube show? So there's been 3 kind of reported times when we're supposed to use an NG tube for GI bleed. The first is with coffee grounds, like this lady has, right, to look for an active bleed, and then melena and hematochezia to look for an upper GI source, right? So this has actually been studied a fair bit. They've asked patients, like, of all the procedures we do to you, if you're a person who gets a lot of procedures, what was the worst one? And patients pretty consistently rate this the worst procedure. So it's definitely not something to be taken lightly. The other question is I find the problem with this to really be false reassurance as well, right? And so, as we all know, most of the time we put an NG tube in, if we get an x-ray afterwards, the tube's coiled up in the stomach. And so if the bleed is post-pyloric, you're going to get a negative aspirate even if they're spurting out blood actively. The other issue is, or the pushback I've had from GI is, well, if you aspirate and we see bile, then we know you're kind of post-pylorus, or we know that the fluid's fluxing back and forth through the pylorus. So they actually studied this, and they did a NG tube, pulled out some fluid, asked the GI fellow, is this bilious or not? And then they scoped the patient and looked to see if they had an active bleed and where the NG tube was. And the bottom line was the GI fellows could not tell the difference between bilious fluid and non-bilious fluid. It was basically like flipping a coin. That's how bad it was. So, I think the bottom line is these can definitely get into trouble with false reassurance. My approach to this is not always super militant, right? I keep in mind that there's 15% in every study that is going to show a negative aspirate with a high-risk lesion. But at the same time, if it's positive, some of the studies showed an odds ratio positive for bright red blood of over 10, which is kind of what we want for decision-making. The kind of OR in the meta-analysis is about 4.5. So the American College of Gastroenterology says they're not necessary, so I don't usually do them unless asked, but if I get asked, it's probably not something worth getting in a big argument about, as long as it's going to result in them coming in quicker to do the scope. If you are going to do them, right, I think we all know this, there's pretty good evidence that providing some kind of anesthesia is helpful. So the things that have been studied have been lidocaine in almost any form, so atomizer, lidocaine jelly, lidocaine nebulizer. You should try to give the lidocaine about 10 to 15 minutes to set up, so put it in, wait about 10 minutes before you do the tube. And then the other thing that was studied out of our shop at UVM here was to give the patient some intravenous midazolam prior to the procedure. And this worked really well as well. So whatever's easier for the patient you have in front of you, or whatever you have better access to is great, but either of these options will work, and so you should pick one of them. All right, when should I give blood? So, I think over time, or at least for, my career, when I started out in residency 15 or 16 years ago, the big concern was always transmitting an infection with blood, right? But we know now that it has a lot of other effects that aren't so beneficial. So when do we give it? So the 64-year-old lady comes in, she's got hematemesis ×2, has a history of CADs on an aspirin. You can see her pressure's a little soft, she's a little tachycardic, and her hemoglobin comes back at 9. You don't have any priors, okay? So should we give her blood? So kind of by way of background, if you give 1 unit of packed red cells, you're going to get about 1 gram per deciliter of hemoglobin bump, assuming they're not still bleeding, right? So if you give this lady, if you give this lady a unit of packed cells, she's going to go from 9 to 10. About 10% of all transfusions are done for GI bleeds. This is a pretty important question to answer because we're doing a lot of transfusions for this. The other thing to think about is what the patient's volume status is, right? So if you've got a hemoglobin of 8 and the person looks super dehydrated, they've been vomiting and having a lot of diarrhea and they look like they're really dry, that hemoglobin of 8 is probably falsely high. Whereas if they're euvolemic with a hemoglobin of 8 or 9, you could probably trust that. So some of this is how you interpret what to do with this is going to depend on what your assessment of their volume status is. So, the physiologic reasoning that gets thrown around with this, and I don't want to overly focus on this because a lot of times physiologic reasoning doesn't work out, but just to keep in mind, so bleeding is supposed to induce a hypercoagulable state, and the thought is that when you give a transfusion, you're actually kind of like reversing that process, or you're undoing that process. The other thing that's been shown pretty well is that when you give a transfusion, especially to cirrhotics, it's going to increase the portal pressure, and actually may increase it to like super normal for them levels. So if they started off with an elevated portal pressure before their bleed and you give them blood, they're actually going to go to a higher portal pressure than they were at baseline. And so the idea is that that's going to blow a gasket and disrupt this clot. This has been studied, not a lot, but it's been studied back into the 80s. Most of the studies have some obvious flaw to them, but some of them do show some increased mortality with transfusions or aggressive transfusions. The 2 biggest studies have come out recently. So one was in 2013 in the New England Journal, the other was in 2015 in the Lancet. The New England Journal study was a single center study at kind of like a specialized hospital in Spain, and they looked at transfusing only if the hemoglobin was less than 7 or if it was less than 9. So the restrictive group less than 7, the hemoglobin or liberal group for less than 9. At the bottom line from the study was that there was a mortality benefit, and restrictive transfusion was better for most of the things they looked at. The most benefit seemed to be in the variceal bleed patients, probably not surprisingly because those patients are the sickest. The Lancet study was really more of a feasibility study, so they wanted to do a large multi-center trial, and they're trying to figure out whether or not they could actually study this adequately. So the real trial's in process now, but basically they didn't get as positive results as the group in Spain got. That being said, for what we do now, for most of the data shows that being a little more restrictive with transfusions, whether it's for GI bleeds or for other entities, is going to be better. And so unless something's really pushing you, I would probably lean toward waiting till you got to a hemoglobin of 7 or 8 before you transfuse, as opposed to going with a higher hemoglobin. The one caveat is that every study excluded exsanguinating bleed. So if in your opinion the person's really just hemorrhaging and they're kind of at high risk for acute mortality, then just obviously go ahead and transfuse. And the other caveat is that the study from Spain eliminated people with a lot of comorbidities. So patient with CAD, like this woman in our case here, was eliminated. All right. So last quick question: what do we do with the patient now? So any guidance on how to dispose them? So this is a 37-year-old guy who comes to the ED with vomiting ×2. He's got a mix of blood and vomitus. He basically looks good, right? He's mildly tachycardic. His pressure's fine. His hemoglobin comes back great. He's in the ED for a couple hours and nothing untoward happens. His vitals are stable. He lives nearby the hospital. And so you talk to the GI attending and he says, "Great, send him to my office tomorrow." So is this crazy? Would anybody send this guy home? Right? So probably like 5 or 10 years ago, no, but now people are starting to think about this, right? So there's 3 big scores that look at patient outcomes after GI bleed. So the top 2 scores really focus on mortality, and the bottom score, which is probably going to be more relevant to our question, is focusing on a need for intervention in the hospital. And so each of the scores has different components to it. These have been studied pretty well and validated pretty well. The study from Academic Emergency Medicine came out recently, was more of like a systematic review / meta-analysis. And the study from the BMJ was a large observational trial with about 3,000 patients. The good news is they came to the same conclusion, which is that the GBS score, the one on the bottom there, works pretty well and is probably the one to use in the ED. The other two are kind of less helpful, or less sensitive and less specific. So what's been pushed is that you could send patients home if they have a GBS score of 0 or 1. So the caveats are that the GBS score is really complicated. There's no possible way to memorize it, and so you're going to have to use MD Calc or something like that. The second kind of caveat to this is that no one's done a real randomized trial to see whether or not you could send patients home. So one of the studies that purportedly says you could send patients home had a prospective arm of 80 or 100 patients. So this isn't really super robust data. So I think you kind of have to tailor this to where you practice and kind of what the environment's like where you're practicing. And this is that study over there, this outpatient management. They had a little over 100 patients in the arm where they were doing it prospectively, and basically they only had a small number of patients that they actually sent home. All right, so take-home points. So medical treatment for upper GI bleed is going to be limited unless it's a cirrhotic, but definitely give erythro pre-endo, and then consider tranexamic acid if you're in a pinch and the person looks sick and you're not going to get GI in really quickly. NG tubes are really going to be limited, so just keep that in mind. If you're going to use them, try to do something ahead of time to make the patient's procedure more comfortable. Restrict blood transfusions, and then the discharge from the ED is definitely feasible, and as we move toward more outpatient management, it's going to become more common, but the data for it isn't great. So just kind of tread cautiously when you're doing that. Like Peter and Megan said, I'll be around for questions all week, and definitely feel free to reach out if you need anything. Thanks a lot.
Move around a bit. Good morning, everyone. I'm Steve Bird. I'm from UMass. I'm really excited to be here. I do a bit of speaking kind of around the country, and I love the fact that I can give a talk while wearing a ski sweater. And I hope this is going to be entertaining. My slides you're going to see are different than the PDF that you have. It's better. In fact, I got up early this morning and adjusted a little bit. So what you have on your computer is going to be different than what you see here. It's going to be interactive to a degree. We're going to talk about environmental and toxicologic syndromes based on visual aids. And hope you learn a little bit here. So who's in the audience? Do we have any medical students? No. Any NPs or PAs? A lot. Residents? And others, I guess. I don't know if you have any. All right. Good. So, I'm sorry. Who was here last year? Last year conference. Okay. So I'm giving you a different talk than last year. There's a little bit that's the same, but mostly different. So I was not an art history major. But we know from art that simply by looking at a piece of artwork, you may be able to identify who painted it. So I'm going to show you some paintings by world masters, but they're not paintings that you've likely seen before. And that is the same with medicine. So if we see a picture painted with ballerinas, you know that it is the guy, right? So here's a picture, that's the Eiffel Tower, obviously. And if you zoom in, you'll notice that it's painted with dots. Right, in the style known as pointillism. And if you see something painted in the style of pointillism, you know it's most likely Seurat. Great. Parisian scene painted in the Impressionist fashion. Very good. I do a talk similar to this sometimes with medical students at UMass, and it's amazing. They don't know anything. All right, so slightly bizarre melting clocks. You know, that's Salvador Dali, right? Well, patterns change over time as well. So this, I will tell you, is a master's early work. Does anyone have an idea of who this may be? Ooh. So, all right, very good. It is. So this is Picasso at the age of 13 painted this. Yeah, it's in Barcelona, exactly. And you know, he evolved over time, so this is part of Picasso's Rose period from 1904 to 1906. Here's Picasso's Blue period, where mostly he's painted in blue and more kind of somber things. And then we all know him for the kind of the bizarre things. Yeah, so those paintings are in the Picasso Museum in Barcelona. And then this painted in the style of the old Dutch master's portrait. It is, well, it's actually a Rembrandt forgery. So pattern recognition is not infallible or perfect. All right, so we know that there are lots of patterns in medicine. For instance, this pentad, and if you ever hear pentad in medicine, it's almost always this, which is TTP. There are other patterns which can be a number of things, right? So if you ask a first-year medical student, I have a patient with a fever, sore throat, enlarged tonsils, and swollen, they'll call them glands, lymph nodes, right? They're going to say it's strep, right? And then if you ask a senior resident, they'll add mono. If you add a junior resident, they'll add things like, diphtheria. If you ask an attending, they'll say it could be primary HIV, could be Lemaitre syndrome, etc. And then there are some really short patterns, which there aren't much to them. So when I started creating the talk, I was calling it lightning rounds, and so I decided to have pictures of lightning strikes. So that's what this is. The key from a lightning strike is if the patient comes in alive, they can go home. You don't need to admit them. They only critically ill ones develop rhabdo. They may have ruptured tympanic membranes, but otherwise they can go home. Take a picture and then send them home. Okay, so there are going to be some questions here. You can chat out the answers. What is the rhythm that you're about to see, and what drug causes it? You only see it with this drug. So this is bidirectional ventricular tachycardia. It is pathognomonic for digoxin, the digitalis glycosides. What's that?
I said we don't see it anymore. That's the problem.
Yeah, so in the developing world we see a lot. So there's lots of different digitalis glycosides. Tabetia phenomena, yellow oleander, it's the #2 cause of suicide in Sri Lanka, for instance. So you remember this from Dubin's textbook, the scooped ST segment of digitalis toxicity, or digitalis effect rather, so you see it here. So a little bit about ion conduction with the ECG. Keep in mind phase 0 is sodium dependent, and that causes that's the depolarization of the ventricles. The really important part is phase 3, which is repolarization, which is primarily driven by potassium. Anyone know the name of the primary potassium channel that's associated with long QT syndrome? It's got a really kind of funky name. It's the HER channel, human ether agogo is what it stands for. All right, so the other thing that's interesting and that you need to know, this is totally understudied, I need to write about this, is when you talk about QT prolongation, beginning of the Q to the end of the T, there's two major things that make up the QT. There's the QRS, and what I call here the JT. So you can have a prolongation of the QRS, which will give you long QT, or you can have a prolongation of the JT, which will give you a prolonged QT, or both. It's usually not both. So those differ because, for instance, this is someone with congenital QT, prolonged QT. And you see that QRS is normal, right? So this is all in the QT, or the JT interval, as opposed to this. What drug causes this? Class of drugs. The key is a large R wave in ABR, a deep S wave in 1 in ABL. An R wave of greater than 3, I heard it, greater than 3 millimeters in ABR. This is TCA. And TCAs are sodium channel blockers. All right, so they block phase 0, which causes slurring or prolongation of the QRS. All right. None of these should be doing TCA screens in your shops because they are horrible. The specificity is less than 50%, so they should not be done. And the QRS duration is what we use for treatment. So if they're 100 milliseconds to 120, you just watch them. If it's greater than 120, you treat. Okay, I showed this picture this video last year, but it's so awesome I wanted to show it again. So this woman comes into the ED complaining of difficulty walking and a rash, and she's seen by a toxicologist. A diagnosis is made.
Heel to toe.
Absolutely not.
it doesn't show up really well. So there's a picture of her hand, and you see that there are some scaling lesions on the dorsum of her hand, and it really doesn't project well, and there's patches of erythema on the dorsum of her hand. If you look at her feet, now some of this red is toenail polish that's come off. But the same thing exists. There's patches of erythema and some scaling skin. What's the tox diagnosis? It's called Pink's disease. It's called Pink's because of the pink skin, and this is from mercury poisoning. So her family had kept a jar of elemental mercury, quicksilver, for years. It had spilled, and she vacuumed it up. So you can touch quicksilver all you want, but when it volatilizes or vaporizes with vacuuming, that's when patients inhale it and get mercury poisoning. So that's how we always see it, is that someone has quicksilver and they vacuum it up, or it's in the car in the summer and it volatilizes. I've seen kids get mercury poisoning from that.
Tough question. Is that treatable with like ETSA or just you have to wait?
Yeah, so you can chelate. Yep. All right, so what is the plant genus and what's the toxin? Right, so foxglove, this is Pavicia peruviana, yellow oleander, and it has digital glycosides, right? So this is the most common way we see it now. I think doing toxicology in the 1970s would have been awesome, right? Because everyone used DIG, we used theophylline. We didn't have benzos, which are really safe. We had barbs, right? They were really great drugs, probably in the 70s. I wouldn't know. Okay. So young prostitute from Russia. IV drug user from Russia. And then, so what's the drug? Yeah, crocodile. So this is made from codeine. It's made in, quote, labs, unquote, which really means someone's bathroom. And there were some possible reported episodes of crocodile in Arizona. And so we did a Google Analytics search for the number of the searches for crocodile recipe in the English language, and it averaged less than 10 a month. And then there were a couple reported cases, and so we thought maybe we would see a whole lot of crocodile. But it turns out that heroin is just so much better and cheaper that crocodile has not really come about. A patient comes in with metabolic acidosis, and you see this urine. What's the diagnosis?
Antifreeze.
Yep, so what's the antifreeze? Yep, so it's ethylene glycol. And these demonstrate two different kinds of, these are called the typical envelope crystals, and then there are spindle-like crystals as well. So there's several different kinds of alcohol, right? We all know alcohol. There's methanol, ethylene glycol, and isopropyl, and they're very different. Methanol, ethylene glycol give you an acidosis. And the reason is that it is, methanol forms formic acid. That's what causes the blindness and the acidosis. Ethylene glycol has a few bad actors. Glyoxylate is the worst. There's also oxalate, which forms the crystals, either calcium oxalate or hippuric acid. So sometimes lab will tell you, oh, these are hippuric acid crystals. But if you have a patient with a metabolic acidosis and crystals in the urine, it's not hippuric acid, it's calcium oxalate. So what about isopropyl? Isopropyl alcohol, rubbing alcohol, doesn't give you an acidosis. Why is that? Because it forms acetone. You can't reduce this any further. So it doesn't form an acid. That's why you do not get a metabolic acidosis with acetone, with isopropyl. All right. So I took these in Sri Lanka when I was there. So this is a research associate, and this is a patient. What do you see? Nail beds are white. And put a patient on a pulse ox. His pulse ox is 89% on room air. What's the diagnosis? Methemoglobinemia. Good. We see this not infrequently, so kids who get sick can get it. In toxicology, emergency medicine, we usually see it more with patients on dapsone or phenazopyridine. You can also get it with local anesthetics. We don't really see that much anymore. I'm not quite sure why. Maybe GI knows about it. They use them less frequently. So the key is if you see an oxygen saturation of about 85% and it has no change when you put them on oxygen, that is most likely methemoglobinemia. So this is fascinating. You're going to see two videos, which are really fascinating. The first is going to look at someone's eye exam, and the next is going to look at their lower extremity exam. Those are not volitional eye movements. And looking at his lower extremity tone.
I am about to on the north side. You want to take your head?
Chris, would you grab me a shield?
So what's that lower extremity finding? That's clonus. In fact, that's spontaneous clonus, right? His feet were doing this even without any provocation, and when he tried to dorsiflex his ankle, it does it even more. How about the eyes? What was that? So that was initially described in the 1970s with monoamine oxidase inhibitors, which I wish we had now, but we don't. And that is called, it was called ping pong pupils, but we now know that is ocular clonus. So those are manifestations of serotonin syndrome. All right, what's the ingestion? I will tell you that's urine under a Woods lamp. Yep, so this is antifreeze. So antifreeze typically has ethylene glycol. They add fluorescein to the antifreeze so that the mechanics can find the leak in the radiator. I will tell you that some plastic fluoresces as well. So this is more of a, this is kind of cool, but you need to do a positive or a negative control to show that the container you're using doesn't fluoresce if you put water in it. So that's one way that you can diagnose or help diagnose ethylene glycol poisoning, is by fluorescent urine. All right. I guess I should leave it there. If I showed you that, which is a nasal septum perforation, you're most likely going to say it's cocaine, right? But if that same patient has an ulcer on their hand, what's that? This is caused by chrome. Those are called chrome holes, also called dealer's ulcer. So you get the chrome from table games, the yellow in the felt. All right, so this is a fascinating case that we had. It's a young kid who's actually from Russia, and he's working on a scallop trawler off of Block Island, Rhode Island. And they bring up this muck of stuff, and there's something in the rake that they use. He takes it and he tosses it overboard. And within a couple hours, he starts developing pain, and he comes to us, and this is what his arms look like. How would you describe those? Little blisters? Little vesicles? Right, so that's a bulla, right? A coalescence of vesicles that is greater than 2 centimeters. Those were huge. So he, within a couple hours, developed pain and large bullae. What's the diagnosis? Jellyfish. Nope. Not a man-o-war. The thing that he grabbed was metal. This is sulfur mustard.
Oh my God.
So after between World War I and World War II, the United States tossed over into the ocean thousands of munitions of sulfur mustard. And so we've had 2 episodes actually where people have dragged up an old munition. So that is an arm and that's a buttock. Patients feel kind of tired and complain of the skin complaint. They just came back from vacation. They were just scuba diving. Yeah, so this is something else you may see. So this is a hemotympanum. This is mastery. So this skin manifestation, that's type 1 DCS, decompression sickness, that mottled skin. Oh, so this is a patient I saw. I will tell you this, this pupil is about this big. This pupil is about this big. And she just came back from a dive trip. And she goes into the airplane lavatory, sees one eye is huge, pupil's huge, so she comes to the ER when she lands.
Did she get a plant leaf in her eye?
Get a what?
A plant leaf in her eye?
Was it? That's a good thought. So one, if you hear diving, blown pupil, like a catastrophe, right? But this woman was like totally normal, right? She did not have a catastrophe in her brain. So I've seen this a couple times, and I guarantee you have or you will see this. She had a scopolamine patch on, and at one point touched her eye. For those who wear contacts or glasses, you realize how many times a day you actually touch your eyes. I'm kind of surprised you don't see it more often than this. So totally asymptomatic, a big pupil, ask about scopolamine. This is I showed this video last year. Young boy in Arizona complaining of pain. I'm going to show an exam of him, and then and I'm going to skip that. All right. One more. So name the mushroom, name its lookalike, and name the toxin. Yeah, so it looks like a morel, right? But it's a false morel. Does anyone know the toxin? So it's got gyromitrin, which is metabolized in monomethylhydrazine. Anyone know another name for monomethylhydrazine? It's rocket fuel. So these patients, it inhibits GABA synthesis, so they end up with seizures. All right, I have to end, but that's Queen Anne's lace, and that's water hemlock. You can tell the difference by the stem. Water hemlock's really bad, so is poison hemlock, but they're actually different. Okay, so I'll end there. That's what I got my son for his birthday. So thank you very much, everyone. I'll see you around here at the meeting, and I'll be back tomorrow morning. Have a great day.
Man discovers the hole. You can start talking, say hi or something. I'll get this plugged in. I guess. Where's this?
All right, one more talk before the break. Can you hear me okay in the back? Yes? Good?
Up here? What is it? It's the talk. Hang on a second.
Is this thing covering it?
I don't think so. It is.
Can you stick this in somewhere?
Here you go. Do it back here.
No.
Oh no, let's do right here. Make it. Flip it over. All right, just do this one. That's going to be your clicker, I think. That was your clicker there, so you want to stand in front. Yours is up already, right?
No. It should be up, yeah.
There you go. Cool. All right. Awesome. So I think we unplugged the clicker. So you might have to see if I can pop this one in here. There you go. You good?
All right. You can start the clock, Megan.
It's already started.
No. All right. Talk today is how to improve survival of pre-hospital cardiac arrest. So survival rates from pre-hospital cardiac arrest traditionally are super low. In areas like Detroit, they're pushing 0. Most of the US, we're looking around 5 to 10%, but in some parts of the country, it's as high as 50%, like Seattle. So when I got invited to go out to Seattle to take part in their resuscitation academy, I was pretty excited to go out there and see what they had to offer. But honestly, I was also kind of skeptical because I was like, well, that's Seattle, urban setting. Everybody knows they have incredible survival rates for pre-hospital cardiac arrest, but we'll never get those kind of rates in Vermont. But what I learned when we got out there was that all around Seattle is King County, and that actually has transport times and geography not dissimilar to Vermont, and they were getting survival rates over 50% instead of the dismal 5 or 10%. So I started to get more interested. And what I learned when I was out there is that it's not magic. You don't need fairy dust to get these kind of great survival rates for cardiac arrest, but it's not easy either. What you need is lots of basic skills and a lot of organization. And ultimately, it all comes down to time to defibrillation of the heart. You really have about 10 minutes, and for every minute that defibrillation is delayed, there's about a 10% drop in the survival rate. So this is where bystander CPR really comes into play, because bystander CPR or first responder CPR extends the amount of time that the heart can defibrillate, and it can more than double the survival rate. Take a look at this graph. These are pig hearts that are put into VFib, and the red is the ATP level. They were euthanized and biopsied at so many minutes out. And notice how as the time goes on, the amount of ATP in the myocardium drops, and see how that corresponds to the waveform from VFib to asystole. So when you get into the later stages of cardiac arrest, even if you have a successful defibrillation, there just may not be enough ATP in the cell to support the post-shock myocardium. This is just a heart that we're doing CPR on, and that's going to extend the amount of time that the heart can defibrillate. Then we can apply the shock, and it will convert back to a normal sinus rhythm. See how it's going nicely there? So when I got back from Seattle, we formed the VTAC-R program. So VTAC-R, you okay? It's Vermont Alliance for Critical Heart Resuscitation. And this is a group that includes all the people in the chain of survival to improve cardiac arrest. So first, 911 operators, the bystanders, your first responders, EMS, hospitals, all working together. We also participate in the CARES registry, which allows us to measure what we're doing and improve our performance. So VTAC-R has 5 key elements that we'll talk about. And first of all, the 911 dispatcher plays a really important role, both in dispatch and getting the bystander to start CPR. When you call 911, you get a public service answering point, or a PSAP. These are the PSAPs in Vermont. They're scattered all around. And the operators, they have 2 big responsibilities. One, they have to get all the information on the call, and then they either dispatch EMS, or in a lot of cases, they transfer that call to a local dispatch center. So that all takes some time. Number 2, they want to try to get the bystander to start doing CPR on scene, for all the reasons we talked about. And it's not so easy to recognize cardiac arrest over the phone when somebody calls you and get them to start CPR. So we teach the 911 PSAP operators to ask 2 key questions. 1, is the patient conscious? And 2, are they breathing normally, including agonal respirations? And if the answer to either of those questions is no, we try to get them to start immediate CPR. So it's not always so easy. Take a listen to this actual call.
He's conscious, he's not responding.
Okay, and are his eyes open?
His eyes are open. Barely.
Okay, and he's not responding to you at all?
Not responding at all.
Okay. How's his color look?
And, there's the point, it was normal.
Okay, how is he breathing? Is his chest going up again?
Okay, so that went on for almost 8 minutes before CPR was started. Now listen to this example. It's another real example that we actually got on film of a call taker that quickly goes through the 2 questions, identifies cardiac arrest, and gets the caller to start CPR.
911, what's your emergency?
You gotta help me!
Listen, ma'am, calm down.
No, wake up!
Is he conscious?
No, he's not looking at me. He won't answer me. Something's wrong.
Ma'am, again, listen, focus here on me. Is he breathing normally?
He's breathing, but it doesn't sound normal. He's gasping.
Okay,
Sounds like he's smoking.
that's not normal breathing. What we need to do is start CPR.
Okay, it all comes down to the slope of doom. All right? You have in a resuscitation about 10 minutes to defibrillate that heart and get a return of spontaneous circulation. And there's things that we can do, either through high-performance CPR or through rapid dispatch, that can start to flatten out this slope and improve survival rates. So take a look at a typical EMS system. The call comes into dispatch. They have to process it, get all the information, transfer it to the dispatch center, and then also talk to the person, and it takes about 2 minutes. The call goes to the local fire EMS department, and they roll wheels on the road after about a minute. It takes them 4 or 5 minutes to drive to the scene, get to the patient's side, and start CPR, and they administer their first shock, and we have a 10% survival rate. Now look in this high-performing system. Dispatch here shaved a minute off. How? They do parallel processing. So they're like, hey, we got a call here. One person is talking to dispatch, the other one is talking to the bystander. 2 people working in parallel instead of serial processing of the call. They get the same turnout, but now look, they've started telephone-assisted CPR, and that starts to flatten out the slope of doom. EMS takes the same amount of time to get there, but then they start the high-performance CPR, and that flattens out the slope just a little bit more. Now when we give our shock, we're at a 50% survival rate, doing much better. That's what we're striving for. And we actually have metrics for Vermont 911 system. We try to measure, we see that they can recognize a cardiac arrest within 1 minute of getting the phone call, and have CPR, hands on chest, started within 2 minutes of receiving the phone call. And we kind of QA those 911 calls. We listen to them and we give the operators feedback. So the next element in VTACR is the high performance CPR. It's also known as like pit crew CPR, because everybody has a job and the whole system is very orchestrated. And because of that, it just goes really well. The key components of high performance CPR, you want to have the right rate, 110 beats per minute, with a depth of 2 inches, and a big emphasis on minimizing pauses in compressions. So we talk about the chest compression fraction. We want to keep hands on chest at least 80% of the time. You would not believe how often there are pauses in CPR. Like we had studies where they followed EMS around with a stopwatch, and every time there's a rhythm check, person's getting carried down the stairs, loaded onto the stretcher, put in the ambulance, there were pauses. And CPR was only being done like 50% of the time. So with high performance CPR, we strive for more than 80% compression fraction, and good crews can keep it up over 90%. We want to have full chest recoil, no leaning on the chest, and avoiding hyperventilation. So this picture shows the hemodynamics of CPR. When you compress the chest, blood is circulated to the body. And you can see that both the atrial and the aortic pressures go up and blood gets circulated. But when you have recoil or release the chest, that's really important too, because that is what happens is right here, the aortic valve slams shut. You maintain some aortic pressure, but the atrial pressure drops down. And it's this pressure gradient that allows for back pressure. And this is where the blood flows through the coronary arteries and actually supplies the heart itself. So if you don't have full recoil off the chest, then your atrial pressures get elevated and your coronary perfusion pressure drops. So you have to think compress for the brain and release for the heart. Pauses in CPR are deadly, okay? Every time you have a pause, your pressure drops by, the aortic pressure drops to 0 in like 3 seconds. And it takes a good 20 seconds to ramp it back up. So in high performance CPR, we do continuous compressions. We don't stop for anything except the rhythm analysis. And those pauses that we do allow are for 10 seconds or less. All the interventions, IV, IO, intubation, medications are done without pausing compressions during CPR. And it's those pauses, like when you do before a shock, that can be really bad. Every 5-second increase in a pause is associated with an 18% drop in the survival rate. This is the Vermont protocol. So for high performance CPR, so notice that all these red blocks are 2 minutes of CPR. In between the 2-minute blocks, we shift compressors around so nobody's tired giving CPR, and we do a less than 10-second rhythm check and the shock if indicated, and everything else is done during compressions like intubation, IV, IO, meds. All right, so here it's just a 90-second clip, but it kind of shows you the whole thing put together.
Hi there.
Checking responsiveness and initiating CPR should take no longer than 10 seconds.
Now breathing no pulse, begin CPR.
So that was fast.
Compression should be continuous at a rate of at least 100 to 120 a minute. Compression depth should be at least 2 inches with complete recoil after each compression. Utilize monitor for immediate feedback. Compress for the brain, release for the heart. Ventilation rate should be 8 to 10 a minute with no pause in compressions. Each ventilation should be no longer than 1 second, with just enough air to make the chest rise. Limit volume to 300 to 400 milliliters of air. A 3-finger squeeze helps limit volume. Rotate compressors every 2 minutes during the breaks for rhythm checks. Pre-charge monitor to the appropriate joule setting 15 seconds prior to each 2-minute rhythm analysis while continuing CPR. Interruptions in CPR should be no longer than 10 seconds. Check femoral pulse during CPR and pauses to allow for rapid detection and return of spontaneous circulation. Hover hands just above chest while analyzing rhythm and during defibrillation to minimize pre- and post-shock times.
And let's go ahead and give them our next med. And if you're ready to do the airway, okay?
Establishing an advanced airway should take place without interrupting chest compressions.
So I don't know if you caught all of that, but before they paused, they charged the monitor and kept doing compressions while charging. Then, when they did pause, they shifted compressors. Their pause was less than 10 seconds. They hovered the hands, and the second they gave the shock, they were back on the chest. Intubation is during CPR, so that takes some practice. A couple of other elements of VTAC are, in the hospital, we do targeted temperature management. That's where we cool the patient down 33 to 36 degrees for 24 hours. That helps prevent brain damage and improves neurologic outcome. And finally, we participate in the CARES registry. This is a cardiac arrest registry to enhance survival. It's about 1/3 of the US population contributes to this registry, including Vermont and the other northern New England states. And we measure things like what happened in the EMS environment or in the hospital environment. And by collecting all this data, we can assess how we're doing, QA ourselves, and make improvements and then measure it again. So finally, I just want to share a true success story with you. This was Chief Buck. He's a local police chief in Richmond, Vermont, the town I live in. And he had a very exciting day this past October.
Chief Alan Buck recalls the most stressful day of his career. October 20th, 2017. At one point, the Richmond police chief was the lead cruiser in a pursuit that would span several towns. However, Buck only made it a few minutes.
All I remember is probably midnight said I gotta stop. Something's not right. And that's the last thing I remember for the day.
The chief was having a heart attack. Sarah Land is a paramedic with Richmond Rescue. She was the primary care provider on the ambulance that picked up the chief.
I asked our dispatch if they could confirm what I was hearing, and they said, yes, CPR is in progress, but they need an AED. So your veterinary said, please tell them he has one.
Chief, who had played a role in making Richmond's heart-safe community, never thought the AED would need to be used for himself. Sergeant Bradlin was able to start using it before rescue got there.
There were several other law enforcement agencies on the scene prior to arrival, and out of all of them, there was a single AED.
So they shocked him 5 times on scene and 9 more times en route to the hospital. He got ROSC. He went to the cath lab, got a couple of stents. He's actually back on work. I'm just waiting for him to pull me over again for my headlight. And so that's it. It's a changing culture. If we all work together, the chain of survival, we can get our survival of cardiac arrest rates pre-hospital up into the 50% range and save some lives. Thanks. Damn.
Are you going to design the drone AED for next week?